When a heart attack strikes, it isn't just a medical emergency. It's a flat-out race, a high-stakes, coordinated sprint against the clock where every single second is critical. Today, we're going to dive into the clinical action plan that transforms that chaos into a calculated, life-saving response.
And make no mistake, the stakes are unbelievably high. This isn't some rare event we're talking about. It's 32 million people a year. To give you some perspective, that's basically the entire population of a country like Peru, every single year. The sheer scale of this is exactly why having a crystal-clear, rapid response plan is so absolutely vital.
So, what's actually happening inside the body during one of these emergencies? Let's break down the biology of a heart attack.
Okay, so the official fancy term is acute myocardial infarction, or AMI for short. Let's pull that apart. Myocardial just refers to the heart muscle. Infarction? Well, that's the scary part. It means tissue death. And why does it die? Prolonged ischemia, which is just a way of saying it's been starved of blood flow and the oxygen that blood carries for way too long.
It all boils down to this. One of the coronary arteries, those critical little fuel lines that feed the heart muscle itself, suddenly slams shut. Usually a blood clot forms right on top of some old cholesterol plaque, and boom, it's like a roadblock. Everything downstream from that blockage starts to suffocate.
Now, from the very second a paramedic or a doctor first lays eyes on the patient, an invisible stopwatch starts. And you could argue that the first 10 minutes are the most important of the entire event. And this is priority number one, the absolute first move on the board. Get a 12-lead electrocardiogram, an ECG, and have it read within 10 minutes. Not 11, not 12, 10. This single test is the master key. Its results dictate literally every single decision that comes next. It's the starting pistol for the whole race.
Now, while that ECG is being sorted, you got to get the patient stabilized. Medics often use a handy acronym to remember the first steps, MONA. M is for morphine, for the incredible pain, but it also eases the heart's workload. O is for oxygen, to enrich the blood supply. N is for nitroglycerin, which helps open up the blood vessels. And A is for aspirin, which is absolutely crucial to help stop that clot from getting any bigger.
All right, let's get back to that critical ECG reading, because the results are about to send the patient down one of two very, very different paths.
So on one side, you've got what's called a STEMI. That stands for ST segment elevation myocardial infarction. Basically, on the ECG's electrical map of the heart, a certain part of the line, the ST segment, is shot way up high. That's a huge red flag. It's screaming that there is a total or near total blockage. This is the big one. On the other side, you have an NSTEMI, or non-ST segment elevation MI. Here, the artery is only partially blocked. Still a very serious heart attack, mind you, but the immediate game plan is different.
So why is this distinction so important? Because the second you have a STEMI diagnosis, all the alarms go off. It means a big part of the heart muscle is dying, and it's dying fast. The clock isn't just ticking, it's screaming. The real race has just begun. Once a STEMI is confirmed, there is one singular goal. It's called reperfusion. It's a fancy word, but it just means one thing. Open that blocked artery and get the blood flowing again. And you have to do it as fast as is humanly possible.
You'll hear this phrase all the time in cardiology, and it's dead serious. Time is muscle. That's not just a catchy slogan, it's a biological fact. Every single minute that blood flow is cut off, more heart muscle tissue dies. And once it's dead, it's gone for good. That's the principle that drives this whole guideline. So, the very next question is actually a logistical one. It's all about geography and time. Can we physically get this patient to a hospital that has a cardiac catheterization lab, a cath lab, fast enough to do the best possible procedure?
And that procedure is called percutaneous coronary intervention, or PCI. You probably know it as an angioplasty or getting a stent put in. It's where they thread a wire up to the heart, inflate a tiny balloon to smash the clot, and prop the artery open. This is the gold standard. It's the #1 preferred treatment, period.
And the goal for this is just incredibly aggressive. The guideline says that balloon needs to be inflated inside the artery within 90 minutes of first medical contact. Think about that. That's from the moment the paramedics walk in the door to the moment the artery is open in the hospital. It's a mind-boggling feat of coordination.
But what if that's just not possible? What if the patient is in a rural area and the nearest hospital with a cath lab is hours away? Well, the guideline has a very powerful plan B. And that's fibrinolytic therapy. The easiest way to think of these are as clot-busting drugs. They're powerful medications, given through an IV, that are literally designed to dissolve the blood clot causing all the trouble. And their huge advantage is speed. A paramedic can give this in the back of an ambulance, buying precious, precious time.
And is it effective? Oh yeah, the numbers are powerful. For every 1,000 patients treated with these clotbusters, about 30 early deaths are prevented. That is 30 people who get to go home to their families. It's a true lifesaver when PCI isn't on the table right away. But surviving the heart attack itself? Well, that's really just the first big battle. The emergency might be over, but the long-term journey to protect that heart has just begun.
And this goes for absolutely everyone who's had a heart attack, STEMI or not. The whole focus now shifts to what's called secondary prevention, which is really just a comprehensive plan to make sure this never happens again. So this is the lifelong battle plan. It's a full-on combination of major lifestyle changes and essential medications. Quitting smoking is #1 with a bullet. A heart-healthy diet and regular exercise, totally non-negotiable. And then you have the medical arsenal, which is just as important. You've got blood pressure control, statin therapy to aggressively lower that bad LDL cholesterol, and a cocktail of drugs like aspirin to keep the blood from getting sticky, plus others like beta blockers to help the heart muscle heal and work better.
So when you step back and look at this whole system, what's the one big takeaway? It's this. A heart attack, as terrifying as it is a treatable emergency. But the line between a full recovery and a bad outcome is drawn by the clock. Success is measured in minutes, not hours. And that's why this stuff matters. Understanding this guideline isn't just about learning medical facts. It shows us that the entire system is built for speed. But it can't kick into high gear until someone, you, a loved one, recognizes the symptoms and makes that critical call for help. Your action is what starts the clock.
Which really leaves us with one final, sobering question. The entire medical system is primed and ready for this race. The paramedics, the emergency rooms, the cardiologists are all waiting on the starting blocks. But what's the one variable, the biggest delay in the whole process that they have zero control over? It's the time it takes for a person to realize something is terribly wrong and finally pick up the phone.